Hello, guys. Welcome to the Sleep Well Journey podcast. I'm Dr. Callie Hale. This is the first episode of 2024. Happy New Year. We have an incredible guest for you guys today. I've been looking forward to this for 2 months. We had to schedule it way back, and I've got Kyle here with me.
Hey, guys.
And on the screen, you can see Dr. Paul Nguyen. So I have a funny story I'm really excited to tell about the first time I listened to him speak, but I want to introduce him. He's an incredible electrophysiology cardiologist. The first time I heard him speak, I was literally standing up, jumping up and down like the weirdo in the audience, like, where has this guy been all my life in dentistry? So Dr. Paul, thank you so much for being here.
Thank you so much for having me. I'm excited as well, and I'm glad that Destiny brought us here today.
Me too. Yeah, so I met you or listened to you. I was going to be your stalker is what it was going to turn out to be. A year ago, I think it was March or May, when the American Academy of Dental Sleep Medicine annual meeting happened. It was in Philadelphia, and I flew down with my amazing airway associate, Dr. Katie, and I think you did meet her in Mexico. I hope she was really excited to meet you. But I had spent most of the meeting being less than thrilled with the content. I flat out walked out on one of the lectures, and I don't really do that. I like to just clap and be everybody's cheerleader. But you got up on Saturday morning, and it was the only lecture I was going to hear that day before I got back on a plane. And I was so down in the dumps by how the meeting went and how much the Academy needed to change its narrative in pediatrics, which I was most frustrated about. And then you got up there, and I literally just think I clapped like every other second, every other sentence you did. And I'm just so thankful that I heard you, and now I've gotten to hear you twice. And the fact that you're on our podcast is such an honor.
Thank you so much. I'm a kid at heart. I'll go anywhere to speak. And if there's one person that is thoughtful and want to absorb some information, I would do the whole shebang, whether it's 1 million people or one. And I'm thankful to have the opportunity to meet you and the gang, including Kyle, because you never know, right? You never know who's listening. But the whole idea here is to be passionate, to be objective, and with clarity. And after 2 sessions and 2 meetings, here we are. And I would go across the world to share my information with you.
Oh, I appreciate that so much.
So I'm really excited. I know or you may remember your Mexico delivery of your message actually ruined that evening and afternoon for my team back at Houston here where we are now, because
you always tell this
because it's true, but it started a conversation that we can't unhear. We can't unknow this stuff anymore. And that's, you were driving home the point, I bet if I listened to your same talk 4 more times, I would take out 4 different key points that I would take home. But your message to me was, you're driving home that result driven outcomes are where we need to focus. And so I immediately went to, well, the patients that Callie's treating, whether it's in a removable appliance like an MAD or whether it was some form of expansion therapy, what did that change? And so we've been measuring diligently. We've been measuring the anatomical changes and also their symptoms, the self-reported symptoms. We have a nice set of questions that are standardized, and they haven't changed. And so, but we've never, before that day, measured blood pressure as it relates to one of those outcomes. And we're a good dental office, so we measure blood pressure every single time, every time they walk in. It's something that we're diligent about, and I think it's something that sets us apart in other facets of healthcare, where we see our patients sometimes 3 to 4 times a year, and we have blood pressure readings on them 3 to 4 times a year. And so we can go back and look at the history, and there are several patients that, we had a lasting impact according to their blood pressures. We had a lasting impact on their cardiac fitness, on their blood pressure showing up to the office, which is usually a scary place to be anyways, the dentist, and seeing those changes. And that was really motivating for our team here, because we're doing something that's different, or doing something that's challenging. And most recently, we have patients that they saw an outcome in another patient that was maybe someone who referred him to the office, and they didn't get that same outcome, whether it was perceived or real. And those are really hard conversations to have, because Callie and Dr. Goldberg and Dr. Hicks and Dr. Aparicio, all our airway dentists in our group, they want to have 100% success all the time.
I really do. I struggle with that.
They beat themselves up when they're at 95% success. And so we've been making this shift, and blood pressure is not something that you feel. And we get told that in dental school. I'm sure nurses get told this. I'm sure anyone that learns about hypertension, they get told you don't feel hypertension. You don't feel the disease like you do many other diseases. Like you get the flu, you feel sick. You get high blood pressure, you don't feel anything until you have that one event that everyone's afraid of, and that's the major cardiac event. And so I just gotta thank you, because your Puerto Vallarta delivery really gave us that second and third win that we needed.
Definitely.
Because it has been a really trying 3 months here, not because we're doing something different. We opened up 2 offices from scratch, built around doing this, and our message around these. And we're not funded by some giant firm somewhere giving us all the money that we need. I mean, we're inventing the wheel, and then the spindle and the steering wheel and the tires and the headlights, all of it's getting invented, but we know we have an awesome mission. And so I just before we dove in too deep, wanted to thank you personally, because you have had a huge impact on me and our whole organization. So thank you.
Yeah, so I do apologize to the staff.
You do not owe them anything
anymore. But I can safely say, though, being an immigrant from Vietnam when I was 6 years old, I was happy when I had 0. So when you acquired more, then you become extremely objective on putting things together. I think the healthcare system is divide and conquer, and that division and conquer actually makes the patient, evolves the patient into the victim. This conversation today is an amazing conversation. And like I mentioned to Callie earlier, I would go across the world, because this was not meant to happen. An electrophysiologist, cardiologist at this level, with dentistry at this level, to go back to literally the grassroots. Blood pressure. You are the expert in dentistry. You know this more than all of us. So therefore, the only chair that's empty right now in my medical team is the dentist. We rely on you. I can ablate, I can put a pacemaker, defibrillator, and do all this, but the cost and the complication is just crazy profound. But to look at somebody here from day one at this height to prevent is powerful. So I'm all about treating after the fact in terms of my specialty, but that's not a success. That's a failure on my end. So we have to go not backwards. Actually, this communication, this interaction here today is so critical and powerful, but yet so simple.
Right.
And people are not putting that together. So if you reduce blood pressure and maintain it. So has anybody knocked on the door and said, Dr. Hales, you can't take blood pressure? You're not supposed to know what blood pressure is all about. You're not supposed to have a stroke. You don't need to know what a heart attack is until you have one and get a stent and bypass and pacemaker. No, you're those people that our community on your chair, in your chair right now, those are the people that you're preventing. So if you're dealing with them at 12 years old, 14 years old, what happens to them when they're 20? It's powerful, yet you need to really clarify that. Just because I'm a cardiologist doesn't mean that I am the guru in outcome. Right. The outcome needs to be simplified and easily translated. So when I was there in Mexico, when I heard both of your talk, and I'm like, oh my God, this is literally a swimming pool of data that's so simple.
Right.
Yet there's no connection between my service and your service. But I know that's obsolete. So from this point forward,
Yeah.
this is a interaction relationship that should be lifelong, and it's our true endeavor.
I appreciate that so much.
Absolutely. So one thing, I was going through my notes and I was hoping you use this as a point to kind of start talking about, I don't know, for us, we call it like, what's the phrase? Like dental IQ, right? Wherever patients, we talk about dental IQ all the time. I'm sure you have something very similar in medicine. And one thing that you said was the extremely low rate in which I wrote down heart failure patients get therapy by physicians. And so, when when I'm seeing a patient, their blood pressures are routinely, especially the men, the women too, but especially the men, excuse me. They're coming in with 155s over 100s. They're coming in with 175s on stressful days. And the uphill battle I have with all of them is, one, I'm still a lot younger than most of them. And two, it's like you were saying, that's not something we're supposed to be talking about at the dentist's office. But I have to take your blood pressure, and I do actually have to measure the risk of giving you local anesthesia with epinephrine, determine your ASA category, and titrate my dose, or maybe delay treatment. And so, as a early in career dentist, I won't say young dentist, but early career dentist, what tips do you have for me talking to my patients when they come in and their initial blood pressure reading is 185 over 112? And that's routine. That's going to happen this month. That's going to happen next month. And for me personally, in the education that I have, my mentors and my professors have taught me that I need to stop treatment or delay treatment if they come in with an initial blood pressure reading of 180 over 110, 170 over 110. That's my cutoff point. There are others who are less confident. We're a well-prepared office. We do emergency training. We do things, but what I'm telling myself and my patients and my staff is that we're prepared for we can carry the risk of a 169 over 109 coming in, who's going to get maybe 75 micrograms of epinephrine and maybe 200 milligrams of some sort of local anesthesia, whether it's articaine or lidocaine or mepivacaine. But we're okay doing that thing. We're also okay putting them under intense stress because we're going to pull teeth out of their head, right? Like the pharmacology aside, like the thought of having your teeth pulled makes people sweat. So, just as a selfish question, I guess, help me approach some of these patients who are sitting here and never had a heart attack. They're 62 years old. They're never going to have a heart attack in their own mind, even though their dad probably died of one.
Yeah, so from my end, I think the approach is that you have an opportunity to make a difference.
Mm-hmm.
And I'm just happy that you're thinking about the blood pressure, because if you didn't take the blood pressure, how would you know?
Right.
But since you took the blood pressure, now you're responsible for the number. But the ability to have blood pressure when you're stressed and thinking about the needle, think about the extraction,
Right.
blood pressure is good for you because during times of stress, you demand more. So that demand is there, just like a sprinter, right? If you're sprinting and you want to win the sprint, you can't be at 90 millimeters of mercury. So these guys sprint at short distances. A higher blood pressure is not terrible, but it gives you an opportunity to say, what else? What else? Is the patient compliant with blood pressure medication? Did they take it this morning?
Mm-hmm.
And since you took it at 180, did they take it? Were they so nervous and stressed that they didn't take it before they saw you? Mm-hmm. So there is an opportunity to really work through a platform and a workflow to where everything is standardized to say all of our patients take their blood pressure medication before they see us. And if they're hypertensive, this is an opportunity for you as a clinician, as a certified provider, to talk to their primary care because they haven't seen it for 6 months.
Mm-hmm.
And you're the one that actually can make a difference. And if you're dealing with oral appliance and sleep apnea, reducing blood pressure 5 to 7 millimeter of mercury reduces stroke risk by 25 to 30%, heart attack by 25%,
Yeah.
heart failure, number one diagnosis upon discharge, the epidemic, the pink elephant that all of us are responsible for in terms of readmission and length of stay. You think that's not my problem. That's all of our problems.
Right.
So if you can deal with that blood pressure at that point in time, you make a huge effort that you may not know before, but you know now. So first things first is, hey, take the blood pressure on both arms. Make sure that they're equivalent. Give the patient 10 to 15 minutes to really relax a little bit and say, hey, you know what? Here goes a stress ball. Just squeeze it. Relax.
Yes.
We're the podcast team, and just listen to this thought a little bit so you can relax a little bit, and then take the blood pressure again. But when you do sedate, when you do calm down, that blood pressure will go down.
Yeah.
So when a patient's an emergent, case to where you need to expedite certain things, don't let that 180 slow you down, provided that you know the patient well.
Yeah.
Obviously, as the first encounter, it's a different story. But again, work through the standardization to where take your medications early. And guess what? I'm just giving you a thought. Non-compliance is huge in hypertension and heart failure. Yet you have developed a workflow to improve compliance. That's the bottom line, right?
Absolutely.
So it's an opportunity for you. So simple, so powerful.
I love that. Thank you.
Why is non-compliance so low on that?
So non-compliance is actually very high.
No,
right?
he's saying
not me. Why is non-compliance so high? Sorry.
Yeah. So non-compliance is crazy because people don't feel well. They feel poorly. They're depressed. They're anxious. After 2 years of COVID, I'm overweight. I'm deconditioned. I drank a little bit more. I sleep poorly. I gain weight. I have apnea, but nobody thinks about it. I think I can go to work tomorrow. I think I can go to the gym. Then I go to the dentist. My dentist looks at my blood pressure, does all of that, and is the instigator, the initiator of my total health. While, my internist, my cardiologist, I'm not going to see him for the next 6 months anyways.
Right.
So again, it's an opportunity for my dental colleagues, for both of you to make a difference. The non-compliance, people don't talk about non-compliance. Oh, you didn't take your medicine, right?
Right.
But what happens if you go home from heart failure and having a stroke and you can't afford medicines?
Right.
If you can't afford medicine, does that mean you're non-compliant? No.
Definitely not.
Yeah.
Definitely not, right? So I'm one of those guys that go, hey, you know what? I don't think your insurance pays for this stuff. Let's take this. That conversation, as a private physician, that conversation is extremely robust and objective.
Yeah.
And I think that not only taking blood pressure, but what you guys are doing is very powerful, but also to really hit key things. When were you admitted for hypertension?
Right.
How many medications are you on? Typically, a blood pressure patient, moderate, is on 3 medications, right?
Right.
And talk about affordability, because if both of you, your listeners, can actually improve compliance, and that's the answer to
Absolutely
our failure, it's crazy. So that's why this connection is powerful, because I think sleep apnea, I think the dental side, my providers can really help us to improve compliance. And we are failing that royally on a day-to-day basis. We can have a huge critical thinking discussion, but nobody talks about compliance.
right.
And that's the issue.
Wow.
I think for us, the same thing is like you said, we took the blood pressure. Now we're responsible for it. And that's, many dentists, I actually don't want to say most, but many dentists are pretty good at blood pressure like we are. It is a state required thing, and most states are very similar in their requirements. So, but I know I know my colleagues, I know our associate dentist, that is an uncomfortable conversation to have with a patient because we are the molar mechanics and our lane that we feel very comfortable in is way over here, far from blood pressure, but we still had to take it.
And then they're mad at us when we bring it up, or they realize they really want to get this dental work done. Why are we postponing that? Because, they're in hypertensive crisis.
Well, it was probably my first few months out of dental school. I took blood pressure on a patient. His blood pressure was through the roof and his heart rate was like 30 something. And I remember thinking, oh my gosh, he's having a problem. Like
that is a problem.
That is a problem. And so, at the time, my father-in-law had just gone to, I think he was off at a CE somewhere, but he does the highest level of sedation that a dentist can do at the time. And so we had a 12 lead EKG. And so I was like, well, I've been trained on how to do this. I might as well just give it a shot. I got nothing but time because I'm a new dentist. And I put it on and looking at his sinus rhythm, I was like, this is not right. Yeah. And so I immediately thought that, okay, there's no way that I'm going to be 3 months out of dental school and have a patient in my chair having a heart attack or having an issue. And so at that time, I said, hey, I'm going to take this off. We're not going to do treatment today. I think you should go see your physician. And then that's when he says, yeah, I don't feel good either. And I was like, oh, well, why are you still here? He's like, well, I made the appointment 2 months ago, wanted to show up. And then he comes back the next day, thankful because his wife comes back the next day, thankful because he was having, I can't remember what exactly was going on, but he was having a heart attack in the chair. But he walked out and drove himself to the hospital, and he was in the hospital when his wife came and thanked us and brought us cookies and stuff. So for saying you caught this, and that was, so I have this nice little story that I can lean on because it was a first encounter, and a dentist is never going to be better at dealing with emergency than probably right when they got out of dental school, because that's probably the last time they will do emergency training.
Right.
So, I want to.
I think the key thing here is what's important is that don't be afraid.
Yeah.
Don't be afraid. If you want, to tell somebody stay in your lane, I think it's a very bad thing to do because when it comes to healthcare, we should be able to intersect.
Absolutely.
It's
teamwork,
my
gosh. Yes.
Right?
Yes.
So when you see that blood pressure of 200 and a heart rate of 30, so that most common cause of atrial fibrillation, which is stroke. And that's why I would say if we can put together clip notes on key medical things that we need to know, and it starts here at the podcast, with 200 millimeters of mercury, people go, okay, that's just blood pressure. No, most common cause of AFib is hypertension. Mm-hmm. So not only that you have made a difference in reducing AFib, but if AFib was on the EKG, you would have diagnosed AFib and talked and would send that EKG to the internist or the cardiologist. But at the same time, you prevented a stroke because AFib causes stroke. Mm-hmm. So you see, the domino effect is huge. But what I want to do is make sure that you understand that when you approach this, Kyle did a phenomenal job. But I want you to know the phenomenal stuff is what you prevented.
Yeah.
And what we want to do is write that down.
Yeah.
So over time, AFib, all this other stuff. So there's a domino effect here, and I'm glad that you had that that astute acumen to really tailor that case.
Yeah, definitely. I have some questions about AFib and sleep apnea since most of our listeners are listening to us about sleep. But I have a patient recently. He's beautiful family. He told me he was worried about his dad. His dad just got diagnosed with atrial fibrillation. I've not seen his dad yet, but I said, hey, take one of the sleep tests home. They drive 7 hours to see me. And I said, sure, take it. And if your dad, he went to the hospital, he put on all these medications, but never a sleep study. A sleep study still had not been done. And I guess I'm assuming maybe that's just not standard operating procedure. And I said, but I know that it's going to aggravate it. If he's got sleep apnea, then we've got to make sure he's got good oxygen at night. So he took it home. He did a series of nights and AHIs in the high 20s, you know, and I'm like, oh my gosh. And our sleep test machine that we use, it's called Sleep Image. It will actually pick up AFib in the signal line. And it's like the one thing that I like took home when I read that user manual. Like if this signal line is red, there's a problem. You need to refer to internist or cardiology. And I already knew this patient had AFib. So it comes in, signals solid red, AHI is between like 19 and 26. I called him and I said, you've got to get him on a CPAP. Late 70s. And they personally also have a very good relationship, like a texting relationship with their cardiologist. Like I said, great family, and immediately got him set up with a CPAP. And I was so happy about that because I was like, it's not always oral appliance therapy. I tell my patients every day, it's not always the Cali show, right? Like we've got to work together and get the best therapy. But talk to us a little bit about the link between atrial fibrillation and sleep apnea and how that works.
You bet. I think the key thing here is that I commend you that you made the connection between AFib and cardiology. As cardiology, we only see AFib when we see it on the EKG or when we monitor somebody. So let's just take this case. So he's had AFib. AFib comes in many flavors, right? Paroxysmal, you can go in and out. Persistent is you're on it for over 7 days, and long-term persistent. There's several categories. And permanent atrial fibrillation is the AFib that you gave up in restoring normal sinus rhythm. You don't want to shock them. You don't want to give medicines to convert them, just to maintain it.
Okay.
AFib, most common cause is hypertension. Okay. So this gentleman who has AFib should look into hypertension and make sure that's controlled.
Okay.
AFib can go fast and AFib can go slow. Okay. So if you're sleeping and you have sleep apnea and your adrenaline tone is high, your sympathetic tone is high, your endothelial dysfunction leading to vasoconstriction, thrombosis, right? And afterload. It basically promotes hypertension. So when if we're right now on this podcast, if we put, I hate to say this, but if you wear a plastic bag over your face and you duct tape around your neck.
Yeah, we're goners.
We're goners, right? Blood pressure is going to go up. And this time, day in, day out. And, every single day for decades. Next thing you know, blood pressure goes up. The left atrium is where AFib lives, dilates, and now AFib comes out. As it comes out in the left atrium, since it's the left side, clots form in the left atrium.
Wow.
And if it's been on the left side, it goes to the left ventricle, then into your brain. Hence, majority of AFibers have to take blood thinners, and that depends on certain criteria.
Sure.
So therefore, if you treat apnea, whether it's CPAP, whether it's oral appliance, to me, the Rolls Royce, most people think it's the CPAP.
Right.
To me, the Rolls Royce is whatever you use most often.
Absolutely. Amen.
That's the key, right?
Right.
So if you don't drive the Rolls Royce too often, then it's going to be in the garage. Right. So whatever it is, you want to reduce the pressure, increase oxygen, the body. So if I go over there right now and just, okay, Kyle, keep that plastic bag over your face. Now, again, this is just a strange description example.
Sure, we get it.
But what happens to your heart rate? It's going to go up. Absolutely. So treating OSA will decrease stroke.
Yes. Okay.
Limiting hypertension, decreasing AFib. So we can give medication to prevent stroke, to lessen the recurrences of AFib.
Okay.
But the patient is not you can't protect the patient, preserve and save the patient if you don't give air back to the system.
Sure.
We're only covering it up if we don't treat the apnea.
Okay. Fantastic. Thank you. That was a great response.
That was awesome.
Yeah.
So is in medicine is obtaining an AHI not considered one of like the baseline vitals when someone's in and like an advanced ASA category? Like we have blood pressure, we have heart rate, we have respiratory rate, we have temperature, but at that level, is it not common to take a sleep study?
In the American College of Cardiology, I don't think dentists are not, have been prevented to see our guidelines, right?
Yeah.
The guidelines are all there. So American College of Cardiology says that if you have atrial fibrillation and if you have a fib that is resistant to ablative therapy
Hmm.
treatment, that in itself, and just hypertension, that and just uncontrolled hypertension in general. And how many of us have controlled hypertension? If you count, oh my God, they're all above 130, right?
Yeah.
So you need to screen for sleep apnea.
Yeah.
That's in big neons.
Okay.
Yeah.
Okay.
Yeah,
Awesome.
we didn't
Okay.
make
That's
that
good
up.
to know. Yeah.
Okay.
Yeah.
Good.
Yeah. It's just not always happening. But I mean,
Yeah, it's
no
not
surprise.
happening,
Exactly. Right.
Yeah, but I expect, hopefully our dental
Our
colleagues
collaboration.
do that early.
Yes,
Yes.
definitely. For sure.
So is for dentists to get on board, because there's a lot of dentists. We're in this really cool phase right now, and if you rewind the dental clock back 20 years, everyone is getting into dental implants because it just now became acceptable and not witchcraft right around 20, 25 years ago.
Not witchcraft, for sure.
Yeah.
And so now we're getting into, well, dentists treating sleep. We've been
Right.
fringe for a long time, and I think we're on the cusp, if not just past that cusp, of where dentistry treating sleep, airway, kind of synonyms now. Dentists doing that is becoming acceptable, and I think we're still in that blue ocean territory where the waters are very rough because there's a bunch of dentists who think we shouldn't be doing it, period. There's also two specialty groups that think that it's not something that should be done at the rate that it's being done when it comes to oral appliance therapy. And then the education is almost non-existent. It's not standardized. I think the University of Michigan actually has started doing a good job with this. Just from what I've been hearing and what I've been seeing on the internet coming out of that college. But University of Michigan has also historically been the first place to do things. They were one of the big ones doing implants early on. So looking at, what dentists need to, what's your message to dentists who are out there hearing about the impact that they could have, not on their patient's smile, but on their patient's health span and possibly their lifespan too? What's the message to send to them, whether, they're getting out of dental school, they're hearing about this is new, this is edgy, this is maybe not yet trendy, but what's your message to them coming from a place of, we have to reduce readmission, we have to lower blood pressure?
Yes. So the key thing here is in a nutshell. Cardiologists, electrophysiology, open heart surgeons, internists, we're not just responsible for readmission. All of us are. But we took the brunt of saying we will give that outcome and we think it's from a medical standpoint. But we don't realize that healthcare is a continuum.
Mm-hmm.
As an adult electrophysiologist, I see patients at 18 years old.
Oh my God.
So I'm behind the eight ball from the get-go.
Wow.
Right?
Yep.
The problem here is that the dentists should not think of themselves as dentists. They should think, you all have to think of yourself as key providers in the continuum of healthcare.
Absolutely.
Our job is to be more dental-like. Your job is to be more medical.
Yeah.
And the key thing is we can do it at the university, but you and I both know that the power is the ability to translate that at the grassroots.
Yeah.
So imagine if our dental colleagues come out and they have two cliff notes about what is heart failure.
Yeah.
Number one, diagnosis upon discharge. Readmission rate is 20% within 30 days, 50% within 6 months, and literally almost 50% will die in the next 5 years.
Oh my gosh.
Number one cause of AFib is hypertension. And AFib causes stroke. And hypertension class 1, 2, and 3 Therefore, and then you have elevated blood pressure. If you have just, and a normal ejection fraction is 52%, just that on a cliff note, imagine how powerful that would be to have that registry to link the providers.
Right.
If people think up here, then how many more centuries will it take to unite us at the round table?
Yeah.
Exactly.
Sure.
Right? So the key thing is keep it simple.
Right.
But know the knowledge, and then practice the knowledge. Please don't think as a dentist. You are more than just an implanter. Please don't think that.
Yeah.
I'm begging you.
Need to be the title of this one.
I know.
You definitely. That's going to be the title of this one.
Yeah, practice the knowledge. That's perfect.
Yeah. One of the key things, I actually had a follower on the Sleep Well podcast ask me about this because I came back talking about how you said restless leg syndrome should be called panic. I would love for you to explain that.
Yes. So a couple things, and I say this with all due respect for those who have, restless leg syndrome cramps because of electrolyte imbalance. But imagine, let's take Kyle again. I like to use.
I've already got the bag on my head.
Kyle is above 6 foot. Imagine if he's laying supine flat and he has a plastic bag over his face, or push him into a pool and handcuff behind his back. So the first thing is that you're panicking. Therefore, you kick, you thrash. And there's dry drowning and there's wet drowning. So Kyle with apnea, he's dry drowning. So during that state, he will have all these electrolyte imbalances. He will develop cramps. So in a way, you're panicking. Therefore, you kick yourself to get up to breathe. People will have nightmares to scare them out to breathe.
Yeah.
They will move back and forth and they're thinking, hey, it's a habit. I love to sleep on my side. No, your body is protecting you because from an epigenetic standpoint, laying flat would kill you.
Right.
And on top of that, as you already know, I'm glad that Kyle is married because couples have less mortality.
Oh, see, I'm keeping you alive, babe.
Because if you're drowning and you have problems, somebody is going to witness that and help you to get up. And most guys will have enlarged prostate, inflammation. So if you have enlarged prostate, you will acquire and continue to produce urine. Guess what? You're going to get up and pee. So when people tell you, oh, I don't have sleep apnea, I'm a light sleeper, I get up and pee all the time. Those are the mechanism to prevent you from dying.
Yeah.
Oh my gosh.
Yeah.
Thank you for saying that.
For our ability to move back and forth, right?
Right.
Yeah, so
Absolutely.
your body is it's incredible. It's protecting you. It's protecting you at all times. But hey, imagine if somebody has all that and their providers give them a sleeping pill and not know they have apnea.
No. Oh,
so now they're getting sedated.
I know. Yep.
Right?
It's so bad.
Yeah. And ADD, same thing.
Yes.
Depression, anxiety. Better ruled out apnea first before you label our children.
Absolutely. Oh my gosh. You're my favorite.
Yeah, and then if you're Asian, please, really, we're micrognathic, we're petite, retrognathic. I didn't snore. I have apnea, so I guess it was so bad that nothing came out to snore.
Yeah.
So so apnea is a true silent killer, and I'll give you last 2 seconds. The number one. So for me, my lifelong endeavor is to reduce cardiac arrest.
Okay.
But we're not going to succeed because majority is at home.
Yeah.
I'm not there. Right. There's no AED, automated external defibrillator at home. So in order for us to really reduce cardiac arrest, we got to go after apnea.
Right. Absolutely.
Simple.
Yep. I mean, I think in dentistry, as he was alluding to, it's hard because the doctors weren't trained in dental school about this. I mean, the only thing I learned in dental school about sleep apnea was that you were obese if you had it, period. I mean, it was terrible.
Large neck circumference.
And look where I came. Look where I am now. Okay, I found my way.
Look, I'm 135 pounds. If somebody tells me to go lose weight and go work out, I have apnea.
Yeah.
But I think though, practice makes perfect. So
For sure.
I'm just happy that the podcast is available as a resource, and I'm hopeful that we can make this
For
as
sure.
a podcast resource for people who
Yeah.
want to really get into the understanding of how to be a part of the team.
Absolutely. Well, we're going to have you on again at some point because I feel like we could talk for hours. But I think one of the biggest limitations in dentistry right now for the doctors that are getting into this, the dentists that are getting into this is that we worry about the turf war. We worry about like you said, don't worry about your lane. Learn the medicine and treat the patient and identify this. And one of the hardest things is when I talk to dentists, they're like, "Oh, I don't know. Do I got to refer to internal first or pulmonology or cardiology?" And I'm like, "No, just save the patient's life. Like figure out who is on their team and let them know you've indicated oral appliance therapy, and then make sure it's working. If it's not, rope them in. I mean, just do the right thing by your patient." So hopefully we can drive that home with this too.
Awesome.
Yeah, there shouldn't be any turf war when it comes to the patient's care.
Absolutely not.
Nope.
Yep.
Nope. All right. Well, we do a pass along question, Dr. Nguyen, to our different guests. And our last guest, her name was Stephanie Gonzalez. And can you give them one sentence about Stephanie?
Oh, she's an incredible nutritionist. She really understands food and health and endocrine disruptors, and she treats people virtually. Really cool person.
And so her pass along question to you, she didn't know it was going to be you, was when you go to the grocery store, are you reading the labels and what the ingredients in the labels are?
I am guilty of not reading all of it. The body is a phenomenal system.
Yes.
To where in order for it to repair, it has to be impaired sometimes.
Yeah.
A perfect body is an impaired body sometimes.
Yes.
So therefore, the things that I do like, I wouldn't even read it at all because I know it's junk food. But I think from a cultural standpoint, for me, it's all about greens.
Yes.
I don't call it intermittent fasting, but I eat maybe 2.5 meals a day, a lot of water.
Good.
And for Steph is really omega-3.
Yeah.
So we're pushing that quite a bit.
Excellent.
And number one here is exercise. Yeah. So because of Stephanie, I definitely would read the labels much more.
That's awesome.
But I think that it's a balance always.
Absolutely.
100%.
Okay.
Yeah.
Well, then now we need a pass along question from you to our next guest.
Okay.
Yeah. Anything you want.
Anything. Sleep apnea is not just breathing right. I think everyone has a right to have oxygen. Mm-hmm. And it's probably the cheapest thing on earth, right? If Kyle gets a Ferrari and no air in the tires,
not a great Ferrari.
100 miles an hour. That's right. So now the question here is that, are the providers willing to learn more, to be more medically astute?
I love it.
To serve the community.
Perfect.
Okay.
Perfect. Well, gosh, Dr. Nguyen, I'm so thankful you took the time out of your extremely busy schedule to be on here with us.
Thank you so much. I had so much fun, and I appreciate the question, and I look forward to the next journey.
Absolutely. We'll make sure you get a copy of this.
Real quick, last thing. Yes. One of my front desk, her name, I don't know if she wants to be anonymous. Okay. Call her front desk. Front desk is 32 years old, and at 25, she was diagnosed with left ventricular
hypertrophy?
Pre-activation. I think it
well, honey, you got to get the question right here.
She just moved to Houston, and she's put off finding a new electrophysiologist because she's had trouble finding. She had an ablation at 25.
Okay, so she had pre-excitation.
Okay. Yeah, she had an ablation, and she has intermittent times of feeling not well, and she says the only thing she can do is rest to feel well again. And so she is, what advice do you have for her for finding an electrophysiologist in Houston, which is a huge medical center, but she feels like if she found an electrophysiologist before she found a cardiologist, that she would be in better hands.
The first thing I would do here is that knowing the fact that she had an ablation and pre-excitation, I'm just guessing going off of your history, that it may be a recurrent issue. And ablation is not 100% on certain arrhythmia. So first things first, I would look up an internist first, actually. I'm going to go an internist first that is very good with communication, with community, and they should be ranked there, whether they're part of the health system or not. But a true internist would go up to bat for her. And then from there, because she has a history of ablation, it would be an automatic discussion with an electrophysiologist, because I think he would know who he would send his patients to. And as internists, as an internist as well, we're very protective of who sits in front of our patient to ensure that they're heard. It's not an in and out mentality, because and if she's 32, look at other aspects of it as well, because pre-excitation sometimes is associated with atrial fibrillation, and you may not know you have a fib because it's in and out, that paroxysmal. Yeah, so if you're in it and you're fast, and you may be fatigued, shortness of breath, and you may feel like you're out of energy.
Sure.
But I'll put it back on your lap. Rule her out for sleep apnea.
Absolutely.
Oh, yeah.
No, we'll take care of that for sure.
All right. Well, she'll be really grateful
so
now. I
much.
won't get the stink eye when I walk out of here. From her.
It's my fault. Again, thank you.
Well, thank you so much.
Thank you
I
so
hope
much.
you have
Thank
a
you
wonderful
so
rest
much.
of your month, and I look forward to talking to you
Yeah.
more.
Have a phenomenal 2024.
Thank you. You too.
Bye-bye.
Bye.
Bye-bye.
All right. Thank you for listening to Dr. Paul Nguyen and Callie and I on the Sleep Well journey. We're really thankful that we're being heard, and this is our mission, and it's to not just do better in our own businesses, but to help people out there understand what sleep apnea is for the dentist and how we can play a bigger role.
And really the long-term consequences of what sleep apnea is doing to our families and our bodies, and understanding that, just like Dr. Nguyen said, don't worry about you staying in your lane. Just help the patient. Do what's best for the patient.
Yeah. So we'd love to hear from you guys. You can always reach out to us at thesleepwelljourney.com through the Contact Us page. And if you are a patient or need to refer a patient to anyone, look up theairwaydentist.com. We have a location in Sugar Land, Texas, and also in Friendswood, Texas. And we may be growing again here pretty soon. So we are looking forward to hearing from y'all.